into a space where beauty meets authenticity and transformation is not just a possibility, but a promise. I'm absolutely thrilled to introduce you to someone truly special, Dr. Rukmini Rednam, the compassionate force behind the countless remarkable transformations in the vibrant city of Houston, Texas. Picture this: every curve, every contour crafted with care and expertise, not just by a board-certified plastic surgeon, but your very own cheerleader for self-discovery and confidence. Get ready to embark on a journey where we explore the art of science of feeling your very best self. This isn't just a podcast. It's your cozy corner of empowerment and inspiration. So pull up a chair, pour yourself a cup of kindness, and let's dive into the Confidence Doc podcast with Dr. Rukmini Rednam.
Welcome back to the Confidence Doc podcast. I'm Dr. Rednam. I'm a board-certified plastic surgeon with My Houston Surgeons, and we are in the Houston area. Today, I have a very special guest, Dr. Otto Placik. He is a board-certified plastic surgeon in the Chicago area. And as always, I'm going to ask you, Dr. Placik, tell our listeners how it is that you found yourself in plastic surgery.
So my father is a physician, cardiologist. My stepfather was also a physician. So I definitely was influenced to go into the medical field. And I think both of them being kind of internal medicine, that wasn't my bent. It wasn't my inclination. And so going into medical school, I would always had a creative streak, I believe. And I think of all the fields that attracted me the most, plastic surgery was the most innovative. It allowed you to travel anywhere in the body. And I had a mentor early on who really I glommed onto and really inspired me through the 4 years of medical school and then through general surgery and plastic surgery. So that's how I got there.
That's how you got there. How long have you been practicing?
This is going to be my 30th year.
So just a few years.
Just a few years.
For comparison, I've been in practice 10 years, so I've got some ways to go. So tell us, have you always been in the Chicago area?
For the most part, I was born in Chicago, and then I grew up in LA, went through high school there, and then I actually got into what's called an integrated medical school college. I went to both Northwestern for college and medical school through 6 years. So that gave me a little leap forward. But then, looking at residencies, I had looked at a lot of different residencies and maybe going back to California, but being very familiar with Northwestern, came back here for both general surgery and then plastic surgery in the early years of the integrated programs there. And then did a fellowship in microvascular hand transplant and then facial reconstruction with Dr. Burgett, who you may or may not know. And then ended up looking at different job opportunities and then came back to Chicago for the most part in private practice. But I do have a clinical appointment with Northwestern still.
So what do you use your current practice? What do you focus on?
So for the most part, I do general plastic surgery, which would mean, body contouring. I tend to emphasize less on the face, but if I had to say that I had niches, I do a lot of breast fat transfer, which is kind of unique and been doing that for almost 15, 20 years. And also then I got into this niche of doing a lot of female genital plastic surgery way back when it was forbidden at Children's Memorial Hospital where I trained. It was urology did most of the male genital, and then the plastic surgery department did most of the female genital. So we did a lot of congenital adrenal hyperplasia, got a lot of exposure early on there. But it wasn't really until about 2005 when actually a few medical staff had contacted me about wanting it to be personally done on them. And I had to look into it. And I didn't even know what a labiaplasty was at the time. I thought it was, labia, a chyloplasty, and didn't know what it was, looked into it. And then it was just at the very early years that Dr. Alter had described it. And, it was more in the shadows. And so I had sent a lot of patients early on that were inquiring when it first got big on social media or on Nip and Tuck and some of those TV shows, a lot of my gynecology colleagues, and I thought they would be interested, and they turned most of those patients down.
Really?
And a lot of them ended up bouncing back to me. And ultimately, I had experience in pediatric female genital, but not in adult. And I had some patients, fortunately, who trusted me, and we did very conservative procedures. And then it just kind of evolved from there.
So, what do you see the most common when it comes to female rejuvenation?
So for female rejuvenation, I tend to stay away from the energy-based modalities because the gynecologists do tend to take that over. But for the most part, I'd say about 85-90% is labiaplasty, which is a labia minora, usually a clitoral hood reduction. Then that would go then to labia majora. I would say one thing that I think sometimes some plastic surgeons neglect in doing a tummy tuck is the Mons, which now I also
Mm-hmm.
part of the, the female genital. And so as I kind of went this backwards, I kind of went into female genital, and as I was looking at my abdominoplasty results, I said I could do better in the Mons area. And so essentially the Mons, as you know, fuses with the labia majora, and they almost become one in one with the Colles fascia. So I contour the Mons from above or from below. And so I'd say I'd say Mons actually more in a way than almost anything else. Then it would be labiaplasty, labia minora reduction, then probably labia majora modifications, then probably vaginoplasty, then probably perineoplasty, then sometimes piercing repairs, uh,
Mm-hmm.
and then probably the last is hymenoplasty or hymenorrhaphy.
So, I love hearing you say that about the Mons because we have a saying, "No Mons left behind." So, and it's just because, yeah, for a long time when it came to a tummy tuck, people said, "Okay, well, that's not part of the belly," but really, at the end of the day, it all fuses into one anatomic area, and you can't leave that behind, otherwise, you're not giving your patient the best result. Uh,
Exactly, and I'm sure as you see, most typically that happens a lot in the C-section repairs or even
mhm.
revisions. It just separates and it makes that Mons even more prominent, and that's quite frustrating. I think increasingly as women are wearing more leggings, as everyday wear, that becomes very visible, and I hear that as a frequent complaint.
When it comes to labiaplasties, what do you feel like is one of the most common reasons that women for the labia minora, we're talking about why they come in for treatment?
That's so multifactorial. I think first of all, when I first started doing this, I thought it would be all postpartum, women who had had children, and it isn't that. When we look back on our data, about 2/3 of our patients are nulliparous, meaning not having had children. They are thin. They're actually thinner than my average patient population. They are obviously very well groomed, and there's arguments about that. I think as a
Mhm.
society, we become increasingly groomed, although some people would say that's trying to make people look pubertal. I disagree with that. I think women tend to have facial hair groomed, they tend to have their
Yeah.
armpits groomed, and so they tend to have their legs and their genitals groomed. And I don't
Hmm.
think that's trying to look pubertal at all. But I think increasingly as you lose the protection of the grooming or of the hair, that delicate anatomy gets more and more exposed to trauma. And then we're wearing garments that are even more revealing as a more fit society. So I think that the Lululemon, leggings or the more sheer Lululemon garments reveal everything. And it's really it's difficult to hide or conceal any of your anatomy anymore. Now, sometimes that's desirable. Some people like to show their nipples in garments. Sometimes some
Yeah.
people like to show their genitals. But I think the average person does not like that visibility, and you're either forced to wear some kind of panty liner or protection or shield, or then without any hair there, I always joke if everybody were bald, we'd probably be doing a lot of scalp moles. But if everybody is, if the vast majority of my patients are groomed, you see a lot more anatomy. And generally speaking, women prefer not to see that anatomy, although there's nothing wrong with seeing it. But I think the vast majority of my patients who seek my services don't like that anatomy. So I'd say number one, it is aesthetic. But I think a lot of people, people I respect, like Heather Furness, who've looked back at this and done multiple studies, they showed really people come in for a variety of reasons. So it's rarely just aesthetic. So it may be aesthetic, and then typically it's, appearance in garment adjusting because of that. So they're
Mhm.
physically uncomfortable. Then it's exercise with running or getting on a bicycle or soul cycle or spin class. And then on top of it, it can be hygiene, but women are typically very hygienic. It's not an issue. But sometimes there is what we consider diversion of the urinary stream, and people don't
Mhm.
like the splatter. People get tissue caught on more prominent anatomy. And I think for all of those reasons, I think women are coming in. Everybody thinks that sometimes patients are being forced by their partners, and it's rarely. I mean, the vast majority of my patients are single. They're not currently in an active relationship, and they just don't want to see it and feel that it's more, you know, I don't know, more contoured, I would say, to
Yeah.
reduce the more visible labia. So it's a combination of factors.
I agree with you too. It's at the end of the day, right? Things wax and wane, and what's literally didn't mean to say wax, but like things wax and wane, and what's popular, right? And so at this point, yes, you can see more because of the way that people are grooming now, and clothes are getting tighter and tighter and tighter. So in over time, things may change, and other things may come into vogue again, and maybe that'll change at that point. But I agree. Most of the patients I see who are interested in that, it's rarely that they're, even if they are in a relationship, that their partner is the one that's pushing them. It's usually very self-driven, that they're self-conscious about it, and it's causing them issues, and that's why they want to do something about it.
Yeah, and to that end, I've had like multiple publications on this about, will your prospective partner know? We just recently did a survey of 500 people and showed even a gynecologist, and the gynecologist and the lay people could not tell the difference of unoperated versus operated labia. And then will it affect your deliveries? No.
Mm-hmm.
The same incidence, roughly, although it's poorly reported of obstetric lacerations or injuries, are the same after labiaplasty as they were without a labiaplasty. And will sensitivity be ruined? No, sensitivity
Yeah.
is not affected at all as long as you respect the anatomy. And so I think to a large degree, and then lastly, there's a little bit of a stigma. I think a lot of people, and I think we'll delve into this in the social media part, but there's a stigma of people not wanting to share their experience or talk about it. But at least in my experience in studies, at least 97% of people are very satisfied with their decision. And I'd say to the same degree, we actually did a study comparing breast reduction to labia minora reduction. And
Huh.
while breast reduction is very accepted in society, you know, labia reduction is frequently correlated with female genital or conflated with female genital
Mm-hmm.
mutilation. And it's so different from that. And I said that would be the equivalent of calling breast reduction mammary mutilation. It's not the same. It's reduction of a sexual organ that gives the individual relief from their symptoms or more confidence in their life. And so that's why it sounds bizarre. I very much enjoy doing the labiaplasty because they're one of my most happiest or satisfied patient population.
I think that's wonderful, and I think that the driving motivation for most of not I should say most, all the things we do are for people to feel more confident and feel better in their skin. Do you have a specific technique that you favor for labiaplasty, or do you use multiple techniques?
I do both, and it's been an evolution. I mean, I started with the trim because I think it is the simplest. Now, being the simplest, I think it's also the least prone to complications.
Mm-hmm.
When Dr. Alter described the wedge in 2007, 2008, I kind of shifted to that for about 2 years. But I found that while there's specific indications, if the middle 1/3 is very prominent, I found that it was more prone to complications or dehiscence or edge irregularities, and it didn't give you as comprehensive a treatment of the entire labia minora.
Mm-hmm.
So about 1 out of 4 of my wedge patients came back and said, I'm just not happy with the reduction. I want more. And so I'd say about 95% of the time I'm doing a trim,
Mm-hmm.
but about 10 to 15% of the time I will do a wedge. And sometimes I'll do both. I'll do one on one side and one on the other side, depending on what the anatomy calls for. I think the wedge is excellent. I think there's a learning curve. And most commonly, when I have to fix or repair something, it's usually a wedge that's gone bad more than a trim that's gone bad.
And for our listeners, these are the two most common techniques, really, to do a labiaplasty. And you'll find some people who are all on one side. They say, no, the wedge is better, the trim is better. You can have whole arguments for hours about this. But I think it comes down to what you feel you can provide the best results for your patient in your hands, right? And
I would agree. I mean, we all want to do the least number of revisions and get the patient's best or desired goals or result in the first operation. And I found that with the trim, I was able to achieve that better than with the wedge.
And then just because I am interested, then the hymen reconstruction, what's the population that you were seeing that are desiring this?
So I'd say the vast majority are the Islamic faith or Muslims. I'd say there is a very small percentage that are celebrating a second honeymoon.
Mm-hmm.
And or it sounds bizarre, but I'm not putting words in anyone's mouth, who offer that as a gift to their partner. In some cases, it's where the virginity was taken
Mm-hmm.
without their consent, and they felt robbed and want to offer that, as much as that sounds, to their prospective partner.
Yeah. I mean, at the end of the day, there's no judgment, right? Everybody chooses what they, but it's just something interesting that I saw that I don't think very many plastic surgeons do.
It's very difficult. In fact, it's almost impossible to find articles written on it. I think since I've written, and I've reviewed a couple for the journal, I've got a chapter in one book on my technique, in Dr. Alansad's book and Dr. Hamori's book, textbook on how I do it. But there's very little written about it. And well, increasingly in the past 5 years, there's been about 5 or 6 articles written, but it's one of the rarest and the most taboo subjects to write about.
I understand. I can understand where this coming from. But again, very interesting and very interesting reasons that I wouldn't have even necessarily thought of. Talking about kind of subjects that are sometimes not things we talk about as much. Let's talk a little bit about breast implants. Breast implants really came about in the 70s. There's been different, I think we are now on the 5th generation of breast implants, but there has been some history, and breast implants have gone through their fair share of scrutiny over time. And some people will say that they're one of the most studied medical devices out there, really. What's been your experience since you've been in practice with what your opinions of breast implants and how have things changed over time?
So I'm a little older than you. Actually took over a practice that was started in the 50s. And I saw the evolution of my previous associates doing surgery. But even through my training, we started with silicone, and the earlier type of silicone devices that were less cohesive. And there were some disasters with ruptures and migration of the silicone. Uh, when we had the famous, Connie Chung report with silicone ruptures and autoimmune disease, that was right in my last year of residency. And so that was 91, 92. Actually, I finished in 93, but by that point, almost everyone had gone to saline.
Mm-hmm.
So we went to saline at that point. And for when I finished basically came out in practice in 95, that's all I was doing was saline implants, smooth saline implants. And then we migrated to textured saline implants to lower the rate of capsular contracture. Interestingly, we had just moved from silicone smooth to silicone textured in residency. And then when everything had gone bad, Europe continued to use these textured implants. Initially, we were using some textured saline, but they found that you could feel the rippling of the texture. So we went back to smooth saline and stayed there. And I was pretty late to convert to silicone just because I had lived through some of the problems
Mm-hmm.
with the earlier silicone gel. I don't think I really started doing a lot more silicone until about 2009. And then, of course, went to 2009, and never really went back to textured unless it was for anatomic reconstruction, such as breast reconstruction, where we needed anatomic shapes and we needed the texturing to maintain the orientation of those implants. So for the most part, I now am probably doing about 98% silicone. On rare occasion, I will do saline. Of course, we've had some of our options limited. I was doing a little bit of the ideal double lumen implant
Yeah.
for a while, and that's gotten reinvented. But the the salines I still use occasionally for people who still have anxiety about silicone gel. In rare occasions, people who really want a very exaggerated round look, I will overinflate a saline, or in the instances where somebody wants to go above 850, which we have no silicone implants currently,
Mm-hmm.
above 850, I've inflated some of the silicones to salines to as large as 1300 in a select few patients. And so in those instances, I probably, for probably about a solid 10 to 15 years was doing almost all saline. And it's remarkable that I assume many of my patients will come back to me. I don't see that many ruptures every year. It's a
Mhm.
remarkably low incidence of ruptures, even though typically, like with the Mentor 10-year rupture rate's 10%, meaning if I did 200 in 2015, I would expect that I'd be seeing 20 this year. I just don't see that many saline ruptures.
Mhm.
But having said that, I've gone to silicone. I think right now what's interesting is my previous associate, one did it all over the muscle, questionable subfascial. One did it all under the muscle. And I think there were both advantages and disadvantages to both. And now I see there's a slow trend towards subfascial again.
Yes, there is.
And I'm not sure whether I'm going to jump on that bandwagon. I think if somebody has enough tissue, I might consider that. But that's the one thing where I'm kind of hesitant.
Yeah. Were you using any textured silicone?
Only for anatomic reconstructions or for patients who had repeatedly recurrent capsular contractures, for which I thought there was no other option.
And then do you currently use any textured devices at all, or have you stopped using those?
I've stopped almost entirely.
So my question is, do you still talk to your patients about textured devices, even if you're not necessarily using it, and why you no longer use them?
I do talk to them about it, and I think I'm not generally a fan of anatomic shaped implants because I've seen them either rotate um, or stick in a position which may not be preferable. I kind of count on the drop and fluff phenomenon to some
Yeah.
degree. And so I show them to them. And while I predominantly use, there's no financial incentives here, disclosures, I don't own stock in Mentor, but I predominantly use Mentor implants. And while Mentor traditionally has not been associated with ALCL, I my concern, I do go over the Natrel and
Mm-hmm.
the salt extraction surfacing that has been more commonly associated with ALCL
Mm-hmm.
versus the Mentor texturing technique. If somebody were to insist on it or had a textured device and had a favorable experience, I wouldn't mind replacing it.
Mm-hmm.
I think the textured devices require drains to a greater degree than the smooth ones. And I think increasingly more and more orthopedic literature, as well as our literature, suggests that maybe the drains introduce bacteria as much as they extract it. So I think they also contribute to a biofilm. So that's my personal opinion. I haven't really seen a study confirming that, but I've seen in orthopedic literature that they tend to get away from drains for that exact reason.
Thanks.
So I tend to avoid the texture surface because they need the drain. Because as soon as you get a small seroma, that texturing object may
Yeah.
rotate, and it doesn't maintain the orientation that I prefer.
And I'm in a similar position where I no longer use any sort of textured devices. I'll combine fat grafting with implants sometimes if I really want to achieve a different shape and that more natural anatomic shape. But to me, I do talk to patients about it because just to be complete. But at the end of the day, unless somebody's super insistent upon it, I just don't even feel, even though it is a rare risk, I still just don't think it's worth that risk. And we were talking about BIAALCL for our listeners. So, but I think it's good to be complete anytime you talk about things. But this transit, go ahead.
What I was going to say is that, you asked me, and for a second, I stopped and I paused because I wasn't, do I have that discussion with everybody? To be more consistent, I found myself kind of going on in auto mode, no pun intended, but talking and saying the same thing almost over and over again. And so to make sure that I was consistent, I created a video that I do request my patients to watch. And it literally is without me talking uninterrupted, 35 minutes straight on, where I've covered all these subjects about anate smooth, textured, capsular contracture. And I just want to make sure I get that out there because for most patients, they get in there, they want to do the size and they want to talk about their anatomy. And in a limited time that we have, without spending 3 hours in a consult, I want to really focus on their, augmentation goals. And so that's what I have done to kind of streamline the process in my office.
That's great, and I think at the end of the day, people want to be complete, but yeah, they're like, okay, let's try stuff on. Let's do this. This is a kind of good segue into when we're talking about things. Do you talk about breast implant illness with your patients?
I do, but again, I touched on the subject with the video, and go over the data, roughly as it is that we know. I then, I think I will ask if they have any more questions about that when we're one-on-one, and most people feel like that's been answered, I think, to that degree. I think there's another patient population who do have concerns with both of that and come in
Uh-huh.
specifically for that. And then we will spend more time, and more typically, those are going to be the patients who want implant removal.
Mm-hmm.
And that now I don't want to burden everybody with the on block resection,
Yeah.
discussion. And as you know, Dr. McGuire
Mm-hmm.
and Dr. Glickman have done excellent studies on that, showing that the on block. So I have a personal bias against on block. Unfortunately, I've seen some disasters from those,
Yeah.
and I think it's unnecessarily. I think it's unnecessarily excessive surgery. So unless it's really warranted in true ALCL, I think an on block is overkill.
I 100% agree with you, and that's an excellent paper. When they did their study, they showed that it's unnecessary, and we do put people at risk by doing an unblock, depending on how thick that capsule is, for causing other complications. I think that in plastic surgery right now there is some division. I would think the majority, I feel, would agree with us, but I think that there are still people out there that potentially are spreading some what I would think is misinformation for profit gain, which is very unfortunate. So it's something that social media has also in some ways not been that helpful with, because a lot of it has been propagated by people on social media that is unchecked. You can get up there and say whatever you want to say.
Not only is it, I agree with you 100%, and that's why we wanted to talk, but not only is it promulgated, it's perpetuated, and it's filtered, right? So, I mean,
Mm-hmm.
there is this Facebook group that if you're a plastic surgeon, you can't even join unless you agree to do the on block resections. And so, you're preaching to the choir in a sense, and I don't think they allow an honest discussion of what the risks of on block resection are. And unfortunately, there are some people who really profit from that procedure.
Mm-hmm.
And hey, you and I could make more money by doing more surgery, but I think as conscientious surgeons, our goal is to serve our patients' goals and purposes with the least amount of surgery necessary. We don't want to do a tummy tuck unless it's necessary, but you got the loose skin. There's really very few options. And I think that it's really a shame that good plastic surgeons can't get into those forums and speak honestly, or at least get invited, because they will selectively pick the plastic surgeons or the attorneys who will
Yeah.
support, that cause. And unfortunately, women get fed that. And I've now heard that there is, from my patients, that there is now an explant regret group. That it's
Heard that.
building, that people have been fed, feel that they've been fed a whole line that didn't serve their purposes, and so that's a shame. Nobody wants unnecessary surgery, and I'm not sure if you've experienced that, but I've had a few people who've had the implants explanted and then want them back in.
Actually, just saw somebody this last week
Yeah,
who 2 years I took her implants out a couple of years ago, and she decided she would like them back now. And I think that too is what I tell everyone when I do a breast augmentation consultation is that I'm not very going to argue with you if you come back later and say I would like them out. If you like them out, you like them out. I think it's just this idea is there's this little bit of animosity in some of these groups that think that somehow plastic surgeons will force you to keep these implants, that I've never had to force someone to get an augmentation. They come in quite willingly. So it's, at the end of the day, we want what's best for our patients, but we always want it to be evidence-based so that we're doing things that make sense and we're not just doing things based upon how people are feeling.
yeah, and that's why I really respect Dr. Glickman and Dr. McGuire for doing those studies. It was so needed, and it took so long. We all had an inkling that was what the
Yeah.
results were going to be, but it's nice that she proved it. Now, whether people will believe it is a whole nother. Unfortunately, people make a little too much money from this,
Yeah.
you know,
And
whatever procedure.
yeah. And I've told some patients too, I said at the end of the day, maybe we don't know every last person how they do with certain devices. And if you don't feel the device is right for you, then let's remove them. It's fine. But we don't want to do things that can then harm you by doing too much at that point. So what we're saying, believe it or not, is quite controversial in some groups, and they would not like us hearing this. But I think it's important to understand that there's many different sides of things, and at the end of the day, the evidence base is generally going to be what I would want to go with if I was a patient in those shoes.
Yeah, and so I think that for those patients, I think that's where fat transfer is an option. The SEEF, the simultaneous implant
Hmm.
exchange for fat. Um, I just think patients need to understand that the same goals can't always be achieved with the fat, and it's a different
Hmm.
aesthetic. And that's where I think they're just, and again, I, like the hybrid options, particularly in achieve, I say that breast implants achieve a global enhancement, but fat transfer can achieve a selective regional enhancement.
Yeah,
And
I like.
so, and so I say that I use the fat for sometimes cleavage creation,
Hmm.
or upper pole enhancement. And so that's where I think it's unique. And I think, being facile with all the different techniques helps us to be better surgeons.
Absolutely. If you only do one operation, that's the only operation you can offer. So it's much better if you have a few more tricks, I guess, up your sleeve that you can show people that, hey, like that way I can tailor it to what you need. And it's nice that we're able to talk about this, but we've talked about this just even online that it is very hard in social media to be able to talk freely about a number of the things that we've talked about today. So, what's your personal experience for what you've had to deal with as being a very active social media doctor?
Well, I think, again, being that I see patients being very happy with the female genital plastics, I find that oftentimes I can't really show the results that people want to see. And in the few, social media has evolved also.
Mm-hmm.
Uh, I started out with, probably when you were still in residency, with Musically before it was even TikTok. And then, that got very restrictive. And then I slowly went to Snapchat for a little while, which allowed
Uh-huh.
me to talk about female genital actually film procedures. But even that's gotten very
Yeah.
restrictive. Then went to Instagram. And unfortunately, I see a trend, and we all get it, right? Instagram is not ours. They're allowing us onto their platform,
Mm-hmm.
uh, gratis. But I what's unfortunate is I think that we can't, disseminate the truth by showing true photos of true surgery. I mean, you and I, as members of the society, are bound to not modify our photos, right?
Mm-hmm.
But and I get the legislators' mindset. We don't want to influence the young. We don't want every single 18-year-old to get breast implants. We get that. But I think when you have a filter, it's much more harmful to
Mm-hmm.
someone to achieve results that can't even be achieved surgically. And
Yeah.
more importantly, I see that, as you know, is when we post things on social media, if you do it with AI, it has to be labeled with AI. I think there really should be a filter. I mean, a label for when something's been manipulated with a filter. It's unfair and unreasonable. And I think it's, hypocritical to be able to post a manipulated photo without staying manipulated and expect some young person to think that they can achieve that body type, that
Yeah.
waistline. Virtually impossible. When we post ours, we're showing the scars, we're showing the true surgical interventions and steps. But now that gets screened, that gets filtered, and you can't show it. I literally tried to do a buttock lift, and I had one side lifted and the other side unoperated on, and I had the crevice covered, and it was deemed violence. And so, that was pulled and censored. And I find that very frustrating because I see accidents being shown and very
Mm-hmm.
gory, war photos being shown, and yet a true surgical picture can't be shown. And then on top of it, you've got lots of OnlyFans promotion type websites going on
Yeah.
with much more nudity than what I'm showing, and they're allowed and still up there. And
Yeah.
meanwhile, we can't show, and I think I sent you a picture of one of my patients literally in her bodybuilding competition photos, and that was deemed to be sexual. Uh,
Yeah.
and I don't know how that could be sexual. I've seen a lot more bikinis posted online that are a lot more revealing than her bodybuilding outfit.
I mean, you can see a Skims ad that has more bottom hanging out than I like Skims. But I mean, it's the idea that it's coming from a plastic surgeon that somehow now makes it a bad thing. That's
Right.
basically what the platform has become.
Yeah, and so I think we'll have to. I think that hand's been dealt. I mean, I've seen some outstanding results, from different surgeons across the country, even showing tuberous breast correction
Mm-hmm.
is, something that a lot of young women deal with, are very self-conscious about, and get outstanding results, but they can't show them because they're being flagged or censored.
Mm-hmm.
And I think that's a shame, because I think, it's a great service, and I would consider it more reconstructive yet they
Hmm.
don't want to cover that. And then the hypocrisy of showing women with these baby dolls breastfeeding,
Yeah.
and that there's no way that that woman bore that child,
Yeah.
not that plastic baby, and
They're
yet
like,
they,
okay, you got through the loophole. It's fine.
yeah. So I think we have to deal with that. And so I've dealt with that by going private. And so essentially, I guess Instagram assumes that if somebody's watching my post and they're my private, viewer or
Hmm.
follower, that they can just unfollow me if they see something I don't like. Versus on my public profile, I'm more limited in what I can post. So I'll post the comedic ones, the humorous ones, maybe the
Hmm.
educational ones. But I find that even sometimes the educational ones, like I did a post on a tummy tuck, literally showing the difference between a midi and
Hmm.
or a hybrid type abdominoplasty or full tummy tuck, and that was
Yeah.
viewed as violence and pulled. Now, maybe I had some haters that flagged it, but that got pulled down from my public profile and had to post it on
Yeah.
my private profile. But I think that's really a shame because I think it does serve an educational purpose.
I've been so frustrated. I tried reaching out to Meta and, explain them. And I was basically told that plastic surgery is considered low medical quality, that we aren't considered the same as other medical professions. And, of course, whoever the person on the other end was like, so sorry, this is the blanket answer. And I just, obviously, none of us feel that way. And I don't think all of the people that we've taken care of over the years feel that what they went through was low medical quality care. But I think it is just what the state of things are right now. On TikTok, you can do even less. You can post more longer educational things. And, I've tried doing the two separate accounts too, but that's like even more work to be able to do that on top of our full-time jobs. So I do think it's a shame. You want to be able to share everything, and it's just so selective. It is AI initially that is going through that flags it, but then when it's flagged, then your account, when you're a public account, then it's not shown for several days until it's reinstated. So I don't know what the future is going to change much with that. I think that it just may become that new platforms come up and we have to kind of work within their rules.
I would agree. I mean, I think that I've made a list of some of these. Whether I know some doctors would consider going to OnlyFans, but there was, it seems like Reddit is something that some people are
Yes.
getting onto, which, sometimes I find about these by people saying, oh, that they found me on Reddit, and I was
Uh-huh.
surprised that people were even looking for plastic surgeons on Reddit. But there are different formats, and hopefully some like that. I haven't looked at Truth Social, but you know that I think there's a certain segment of the population going to be looking through there, but and I've not really taken advantage of Twitter or X just because I don't think it's a visual format, and I think most of our patients are looking visually, and that's the appeal of Instagram. It's just a shame that we resort to going to models like this. And trying to get creative with different grapefruit sections. Uh, to
But I do applaud you for being creative with it because, it's you're still trying to do the education, still trying to get out there. You're just having to be, go around their roles really with it because we know in our hearts that what we're putting out there is not anything harmful to anybody.
Well, I would agree. And again, just like you said, we're not dragging anyone into our office. And I think the hardest thing is when people said, I didn't know this was available
Hmm.
because it's kind of filtered from you and that information's kept, uh, you know, by the powers that be at Meta or Google. And it's interesting. One time I even tried to put an ad on Google ad just for breast enhancement with a bikini. And then I had at least 10 iterations of different ads that were all deemed to be too sexual. And they literally were women, what do you call it? Stock photos,
Oh,
different, and in the end, I am taking a ball emoji and putting a bikini on that because that was the only thing that they would accept. um,
I actually had a patient who had O shot, and she was so happy she wanted to write in a review, and her review kept getting flagged. And I mean, this is her review to write it, and she can't even write that in there. And I was like, you know what, forget it. It's fine. Thanks. Thanks for trying.
Yeah, no, I've had a lot of patients who want to write about it. Again, just like you said, it gets, whatever the AI or the screening tools that they use to filter those out. And the frustrating thing is, I think the appeals process is a sham, right? The review process is a sham. I was meta verified before the new certification, and that never allowed me. So then I went and paid the monthly subscription for the enhanced meta verified. And I eventually got somebody, but in the end, it would be like somebody will get back to you in a couple of days, and they never do. And the appeal for a post, it says appeal the post, when it's an educational content. And I've had posts up there for 3 months now in review, saying it'll be 4 days before they get back to you. And
it's gotten longer. It used to be much quicker. They review it like in 24 hours and it'd be fine. And now it's like, it could be like 2 weeks. And you're like, oh, okay. And then once they find something they don't like, then they go back 2 years and be like, oh, I found a post from a year ago that we don't like either.
Yeah.
So I do think that social media plays a really great role in our way to reach people and to educate them. But I think that, we're unfortunately just going to have to work with what they're giving us for the time being. But I think we can still try to fight the good fight and get as much out there as we can.
Well, I always look forward to your posts. They're a lot of fun.
The same. Well, thank you so much for joining us today. This was a really great discussion. I hope our listeners got to hear some things that they just wouldn't get to hear otherwise. And again, thank you, Dr. Placik. He's based in Chicago and is an excellent plastic surgeon. Would you share what your social handle is?
So my website's bodysculptor.com. And then my private Instagram account is at Dr. Placik, Placik. My public one is the pun on the words plastic surgery. So,
and he's pretty funny as well, which is really enjoyable to see. So thank you so much for joining us, and stay tuned for next week for the Confidence Doc podcast.
As we wrap up another episode of the Confidence Doc, I want to extend our heartfelt thank you for being a part of our community. If today's conversation resonated with you, remember that Dr. Rednam and her team are here to support you on your journey to self-confidence and beauty. Your story is unique, and it's our privilege to help you create the masterpiece that is your life. If you'd like to book a consultation with Dr. Rednam, you can visit her webpage at drrukminirednam.com. Fill out a contact form, and one of her coordinators will get with you accordingly.